right. Great, everybody. We are headed back into another fantastic plenary discussion. I'm excited to introduce Dr. Ahmed Salahuddin and Dr. Sean Schweitzer, two of my favorite colleagues I get to work with day in and day out up here at Providence Everett. Um, as background, Dr. Salahuddin was a resident and chief resident at UT Houston. He's a hospitalist at Providence Everett and the associate program director. For the Wazoo Internal Medicine Residency, where he leads the structured didactic curriculum as well as the overall residency clinical curriculum. Dr. Schweitzer is also a hospitalist up here. He prides himself on his use of evidence-based medicine and also teaches Wazoo College of Medicine and UW medical students. He leads the Internal Medicine Residency Journal Club series. I'll pass it over to you two. Thanks.
Thank you. Thank you so much, Delaney. Can everyone see my screen okay? Thumbs up from Dr. Gulay. Thank you. So I'm Ahmed. This is Sean. We're so delighted and pleased to share some updates in hospital medicine with you all today. If you've seen our previous updates talks, that you know that our only disclosure is that Sean continues to like chocolate a lot. So we eschew any chocolate-based literature or research. However, that leaves us with a lot of very impactful studies. This was a great year for it. I'm going to hand it over to Sean to tell you a little bit about how we've curated the topics for today and to get us started because we have a lot to go through. Sean, the floor is yours.
All right. So yeah, I'll first quickly run down kind of how we went through articles. We obviously just practicing medicine, we were kind of reading through the year and impactful articles we kept track of, but we also used evidence alerts, which is a website that you can do that kind of helps curate articles based on interest, and went for their high yield articles, basically the 6 and 7 out of 7-star articles that had high impact. Looked through those and read a lot of them, and then picked the ones that we found to be interesting. We also used New England Journal of Medicine Guideline Watch to kind of curate and look through guidelines that came out in the last year that were impactful. So that produced us with a whole bunch of things that we kind of wanted to talk about. Obviously, we'd have to cut some out. Here's the actual recommendations that are most pertinent to a hospitalist, but we'll look at this in a more visual way. If I can get the slide to advance, there we go. So basically, the things for ACS, they have some new recommendations for antiplatelet therapy. In PCI patients, they actually now have a recommendation of choosing ticagrelor or prasugrel over Plavix. And that is also applicable to CABG patients. For no plan intervention, they're recommending ticagrelor over Plavix. So we'll be seeing these medications a little bit more commonly at this point. And so knowing about that when we're dealing with endostemics would be useful. This slide also kind of goes over that on the left-hand side, but in the middle, draw your attention to the middle area here. The thing that's really helpful for hospitalists is in these, this is talking about bleeding risk. Basically, in patients with high bleeding risk who are dealing with ACS, we have some options to move to single antiplatelet therapy. If you look at this second column here, you can see that they recommend the dual antiplatelet therapy, aspirin plus ticagrelor, for 1 month, but then you can, at 1 to 3 months in a high bleeding risk patient, you can consider discontinuing the aspirin and moving just to single agent therapy with ticagrelor. And similarly, in the middle column there, they have similar recommendations for moving to single antiplatelet therapy in people who are on anticoagulation. So it might give us some ability to kind of wean some of these therapies in people who are at high bleeding risk. The other thing of note is just more formal recommendations about the recommended timing of cath. In high-risk unstable patients, obviously cath right away, but they stratify in STEMI patients based on the risk category, how rapidly they should get a cardiac catheterization. In high risk, wanting it in less than 24 hours. Intermediate risk, less than 72 hours. And then the lower risk is the one where we can still talk about some what exactly we're going to do for risk stratification, but they generally recommend a cath before discharge. The next guideline we wanted to review is the guideline from the American Thoracic Society. This is an update to their 2019 guideline that they did in conjugation with the IDSA guideline. Now, the IDSA and the ATS worked together on producing this guideline as well, but the IDSA chose not to endorse this guideline due to 2 main recommendations that there was a strong disagreement about, so we'll start with those. The recommendations are related to viral pneumonias. The ATS guideline here is recommending empiric antibiotics for higher risk patients who have a viral pneumonia. The IDSA didn't agree with that recommendation because they were worried about this, cause excess antibiotic prescribing. But the rest of the guideline they did work on together, and generally there's some agreement about that. I did post some information directly from Sharon Wiseman, the chair at DSA, that she talking about this. When this guideline is officially published in the paper ATS journal, there is going to be a editorial describing the kind of the disagreement here. But in general, they have a alignment with the other recommendations. So let's talk about those. So the other recommendations is they say that lung ultrasound in centers with appropriate expertise in using it could be an appropriate alternative diagnostic strategy compared to chest X-ray. The other thing that's the more impactful thing is some changes in the recommended antibiotic durations. So in adult inpatients with non-severe CAP, they're recommending a minimum duration of 3 days of antibiotics. So like a 3 to 5 duration, 3 to 5 day duration might be appropriate in these patients. For severe CAP, they're still recommending a 5-day duration for those patients. This might lead to the question, well, what exactly is severe or not severe? Well, in the studies that kind of informed this recommendation, the 2021 study, severe was defined as requiring admission to the ICU. The other study that kind of informed this recommendation was a 2006 study where the severe was a pneumonia severity index of greater than 110. So generally pretty sick patients. People are peri-ICU or ICU patients are the ones that are severe. So these non-severe ones that could tolerate this 3-day course are a lot of the general inpatient pneumonias. If you also want a different way to define severity, you can, of course, use the ATS, IDSA guidelines that are kind of rubric for defining severe pneumonia. The other thing in this guideline is boomeranging back again is steroids for pneumonia. It seems to come and go a lot. In this case, they're recommending only in severe pneumonia. So those peri-ICU or ICU level patients who are really sick, they do suggest systemic corticosteroids in those patients. The next guideline I wanted to talk a little bit about is from the AABB, where there's a recommendation for transfusing to a goal of 10 in patients who are having acute MI. That said, this is a conditional recommendation with a very low certainty of evidence. What they said is that the restriction strategy might result in increased mortality in patients with acute MI. They say might because there's uncertainty there. It's a conditional recommendation with very low certainty of evidence. So let's talk about that evidence. So it's based on 4 trials, the MINT trial, reality trial, and 2 other smaller trials, but most of the data is informed by the MINT trial. The MINT trial might be something that you have a little bit of recognition of because when we presented here last year, we actually talked about the MINT trial itself. And so to remind you about that, the MINT trial didn't actually meet their primary outcome, didn't meet statistical significance, but in a subgroup analysis, they found that there was a statistically significant reduction in cardiac death in the liberal strategy compared with the restrictive strategy, though all-cause death was not different, which is a little weird. I guess they're not dying from heart attacks, but still dying. Is that meaningful? It's not clear. But the other big thing that's really important in that study is that they transfuse almost 4 times as many units in that liberal strategy. So resource allocation could be a concern. So going back to this guideline here, well, what did they do? They took that MINT trial and combined it with the reality trial and those other 2 trials and got a pooled analysis that still doesn't meet statistical significance. It's actually less likelihood of statistical significance. So what's with the recommendation? Well, what they did is the panel met and they decided what they felt would be a minimal important difference based on what they thought patients might value, and they defined their minimal important difference as 1%. So when they did this pooled analysis, if you look on those red boxes in the middle there, what they found was 12 fewer deaths per 1,000 was their point estimate. So in other words, 1.2% better was their point estimate. But their confidence interval was it could be 0.6% worse or 2.6% better. But because that confidence interval contains 1%, benefit and does not contain 1% of harm, they decided that it's enough for them to make a recommendation that we should consider this. Similar reasoning was used for the recurrent myocardial infarction, but it's not statistically significant, so it does leave it very much up to interpretation. And I do worry a little bit about possible harm to the system with excessive over-implementation of this. I think you should really individualize this to the patient and think carefully about when you're applying this recommendation. The other guideline that they went over is the transfusion of FFP and platelets for this CHEST guideline, which has kind of different recommendations here. And basically, if a patient is bleeding, you might consider a transfusion goal for platelets of 50. But first, if they're in WHO group 1 or 2, and I'll go over that in a quick second, you might try hemostasis first. If they're no longer active bleeding, then you just transfuse based on their bleeding risk. If they're high risk of bleeding, then 30 to 50. If they're low risk of bleeding, 10. So this WHO group 2 are basically the bleeds that you think you probably can get to stop, and so have some measures that you can do that. The high risk bleeding, at least grade 3, grade 4 ones that you really don't think you're going to be able to stop anytime soon. That's where you're going to target 50. The other recommendation in this guideline was talking about transfusions for procedures. In general, for internist and bedside procedures, they don't really have any FFP recommendations except for one LP we'll talk about. And for the other bedside procedures, they do have platelet transfusion recommendations, but it's really just following the active, based on the bleeding risk guidelines that I just went over before. So 10 for the low risk of bleeding, 30 to 50 for higher risk of bleeding of the patient, not the procedure, to be clear. LPs are the one where they have a little bit of recommendation of targeting platelets 40 to 50 for LPs, and an INR goal of 1.5 to 2 with FFP transfusions to reach that target. All conditional recommendations based on no randomized controlled trials for the most parts, a lot of observational data, so it's a lot of expert recommendations. So you can certainly make some rational decisions individualizing it to the patient. With this, I'll leave it over to Ahmed.
Thank you, Dr. Schweitzer. All right, and I'm back. Yes, we rehearsed moving chairs between the two of us. So a big practice-changing update by the IDSA, first in 15 years, which is guidelines for urinary tract infection, and specifically complicated urinary tract infection, also known as QTs. And I hope among the many things you take away today, perhaps absorbing a little more of the term QT into your hospital vernacular. But I digress. 2010, the IDSA UTI guidelines focus on uncomplicated cystitis as well as pyelonephritis in women. That's where the data was. And over the past 15 years, we have a bigger base of evidence fed in component by randomized controlled trials to support an expanded guideline scope for urinary tract infection. We now have a lot more data on urinary tract infection in men, so we get a little more nuance there. And you'll notice that the pendulum swing with a lot of IDSA updates in the guidelines towards better antibiotic stewardship. I will flag out, and we'll dig into it, that the classification scheme for complicated versus uncomplicated urinary tract infection is refreshed to be more practical, to better align with clinical practice and decision-making rather than diagnostic descriptiveness. And very importantly, the data inputs to reach classification are better aligned with the point of care reality of most of our clinical encounters with urinary tract infection. To understand that better, let's take a look back at our old classification. Again, it focused on women. You'll notice that a patient is a binary no diabetes or yes diabetes, and regardless of A1C or control, they have a broad brushstroke there that shunts diabetic patients towards a complicated pathway. And then I mentioned that point of care test. I don't know about you guys. I've never had success in convincing urologists to leave their office for a screening cystoscopy to know whether or not a patient has a urologic abnormality or not. So we've done away with that sort of anatomical guidance, and it's mostly based off the shreds of data that we have when a patient's in the urgent setting or emergent setting, which is physical exam, some lab work. Skip below, complicated urinary tract infection. Previously, the goal was to try to include as many people as possible, have a low threshold so that we can save lives. And of course, it's a lot more nuanced and complicated, and we've learned a lot over the last 15 years or so. And then just to draw your attention to the middle there, acute pyelonephritis, it's sort of this awkward stepchild. No real tethering to treatment changes relative to complicated urinary tract infection. So let's look at the new guidelines. You can sort of just visually, just looking at the slide, look at complicated UTI and the old classifications versus the new classifications. So it's kind of a flip-flop in that we're trying to simplify and be a little more inclusive for uncomplicated urinary tract infection. And essentially, and they borrow from European Society guidelines, any infection that's just confined to the bladder. So that's going to be your frequency, that's going to be your dysuria, and of course, you're going to look at urine analysis to guide your treatment choice. So a lot more inclusive, and we'll talk a little bit more about that in a bit. And then to pull back the pyelonephritis, complicated urinary tract infections, all the stuff that we're used to treating, pyelonephritis is now lumped into that because the treatment pathways are the same. In terms of inclusivity, so that we can be better antibiotic stewards, the IDSA does specifically point out that although we don't have a lot of great data for immunocompromised folks with prostatic hypertrophy or cystoceles and also diabetes, they do acknowledge that these are higher risk patients to develop complicated urinary tract infections, anything to extend beyond the bladder. But there isn't strong data to suggest that we should aggressively treat these individuals, that we should be able to classify them if infection is isolated to the bladder to be able to treat them. So that's that pendulum swing towards better antibiotic stewardship. All right, so treatment of complicated urinary tract infection. I think we know it's empiric, not much has changed there, but the specific question of when to transition from oral to IV is basically there's no mandatory minimums. If you get a patient admitted by your overnight colleague and the patient is improving and they can take orals and you have good oral antibiotics available based off your local antibiogram, go ahead and transition it. Certainly look at prior urine cultures, but just plan to treat for E. coli if you don't have it. And then this is important nudge is that the preferred treatment empirically is trimethoprim sulfamethoxazole or fluoroquinolone, which are superior to third-generation cephalosporins in terms of treatment resistance or treatment failures. We should actually give these medications, and I think if you've practiced medicine, especially with a frail geriatric population with a lot of comorbidities, I think we've all been burned by, complications of Bactrim, hyperkalemia, and worsening GFR. And of course, that black box warning of fluoroquinolones is very scary. But nonetheless, we should be prescribing these a lot more frequently because it's superior to third-generation cephalosporins. Nothing surprising or changed here in terms of treatment duration, but it is important to emphasize that if it's a complicated urinary tract infection, you do not have to treat these patients for 14 days, regardless of the type of complication, including hardware, obstructions, et cetera. But use your best clinical judgment. Here is your visual reminder to think about reaching for the Bactrim first. Who doesn't love an algorithm? I do have that visual up there for you guys to look through. Basically, the same stuff we just talked about. And I do have guides for empiric antibiotics, again, emphasizing that the preferred therapy is going to be your fluoroquinolones and trimethoprim sulfamethoxazole, although we can go to the alternative pathway. Lots of big changes there. Next, we're going to talk about AGA updates on portal vein thrombosis, which I'll refer to moving forward as PVT and cirrhosis. PVT is high risk in our cirrhotic patients and can lead to a bad downward spiral in terms of worsening portal venous hypertension, which can lead to worse decompensation and can make challenges in terms of increasing mortality and challenge the transplant success. So the AGA has given us some clear guidelines on how to manage these patients when we do identify it on cross-sectional imaging. So an ultrasound or a Doppler is not enough. We need to get some good some interesting descriptive components to it that our radiologists can call out, including chronicity, whether or not there's collateralization or not, can help us out. And that number to look at is 6 months. After 6 months, you're not going to get much benefit. You're unlikely to recanalize with a blood thinner. So if you start a blood thinner on patients who are at high risk of bleeding to begin with, you're just conferring risk and no benefit. But within that 6-month window, that's our call to action to be able to do things for these patients to help them out. The second thing we need to consider is extent. If it's localized in an intrahepatic branch, you get in the green zone for observation, but treatment if you're more extensive, as shown on the slide here. And then the degree of occlusion is also important. So less than 50% is going to be green for potential for observation. And when I'm talking about observation, I mean no treatment and repeat CT scans every 3 months. What we're doing is we're looking for either progression or regression to determine if these patients should get treatment. Again, with an algorithm. And I do want to flag out something that the AGA recommends is don't hesitate if there are signs of intestinal ischemia. We want to prevent a surgery in a patient population that may not be good surgical candidates, and also lower mortality risk, because that is conferred whenever we have signs of intestinal ischemia. So be on the lookout for that. It can be subtle. Now, if you don't have intestinal ischemia, you have a little bit of time to call your gastroenterology colleague to determine, to risk stratify your patient and do a screening for varices and also size of varices to determine if we can mitigate risk if the patient is to start on a blood thinner for banding or non-selective beta blockers. But we should try to minimize that duration that they are not on a blood thinner so that they can get an urgent endoscopic evaluation. Once you've parsed that out, I have the rest of the flow of an algorithm based off those factors I talked about in the previous slide, with less than 6 months and less than 50% occlusion being in the observation pathway, Q3 month CT scans. And then the treatment pathway, if it's less than 6 months, but a greater occlusion or a main vein. And then again, greater than 6 months, we're just going to watch and monitor these patients. So in terms of blood thinners, I think by now it's kind of well established that DOACs are safer in terms of bleeding risk compared to warfarin, and vitamin K VKAs are going to be very cumbersome, especially for our patients who are suffering from cirrhosis. So DOACs is preferred. And between the DOACs, now there wasn't a head-to-head trial between apixaban and rivaroxaban, but apixaban does have data for the use in Child-Pugh Turco class B, whereas rivaroxaban is not advised because there's no data there. So pick apixaban. And then lastly, look at the first and the last bullet. I just want to emphasize a multidisciplinary approach is the right one for these patients because there's nuances outside of the algorithm. For example, you may just want to give anticoagulation for patients who are on the transplant list just to optimize the chance that there's recanalization, make sure there's no progression so that they can get that transplant and it's successful. Similarly, talk to your hematologist if there's a co-occurring hypercoagulability. All right, there are your takeaways for you to review. Okay, and this one is a really juicy practice-changing update. The first in 15 years by the American Diabetic Association, focusing on hyperglycemic crisis in adults with diabetes. So some stuff you already know is the clinical picture, but they wanted to emphasize that a third of hyperglycemic emergencies have a hybrid DKA and HHS presentation. And here are your diagnostic criteria. These are the new ones. And they leveraged acronyms to help us stick in our minds. And they got a little bit creative with HHS using the third letter for the absence of significant ketonemia. And I do have highlighted the values to meet those criteria. So one thing I want to spoiler there, look at DKA and something that is missing, glaringly absent is anion gap. So we're no longer minding the gap. There's good reasons for that. So I want you to just picture in your mind cases of DKA that you have taken care of where the gap closure or a persistently open gap may not have clinically correlated with how the patient's doing at the bedside. So there's physiologic reasons for that. Number one, when a patient comes in with DKA, they are volume down. And our ability to measure anion gaps is based off of our serological markers and concentrations of anions and cations. So there's a lot of volume contraction and contraction alkalosis there. So it's not really accurate as a patient enters while they're still volume down. And what do we do with our volume contracted patients? We give a lot of unbalanced crystalloid. That's what we typically do, and that's what the guidelines have asked for, isotonic normal saline. And what is this unbalanced fluid have a lot of chloride. So even if you volume expanded and they're doing better, anion gap is just not as accurate. What is accurate, so moving up So old on the left and new on the right is beta hydroxybutyrate. That's what we're going to look at instead of an anion gap to qualify if a patient has diabetic ketoacidosis. I want to flag out that we're now looking at quantitative, whereas before it was kind of a yes or no situation. I also want to flag out that we now are more inclusive for folks with a history of diabetes, regardless of the blood sugar, to make room for euglycemic DKA in the era of SGLT2 inhibitor ubiquity, which is correlated with rates of euglycemic DKA. All right, so here are our algorithmic pathways between insulin and IV fluids. Let's start with insulin. I do want to flag out that we now have new recommendations to treat mild DKA, and here are your parameters for mild DKA on this box. Treatment with sub-Q insulin. You can keep them in an OBS unit. You could eliminate the ketones and get them out of the hospital. But for everyone, including mild DKA, if a patient is on basal insulin, go ahead and give it. I think previously we wanted to have optimal control of the patient. We don't know where they're going to be, if they're going to eat, if they're going to need surgery. But ultimately, in practice, think about it, your long-acting basal insulin, it's going to take about 12 or so hours to reach its optimal concentration. Usually about 12 to 24 hours is when you're pulling a patient off of their insulin drip. And that's also the time that you're going to get burned with a rebound hyperglycemia. I'm sure all of us has experienced that and been disappointed with it. But if you have that gentle basal insulin on board, you're going to have a better shot at not having that rebound hyperglycemia. All right, and let's just look at fluids real quick. I'm just going to focus you down to the other crystalloid, which is a little demure suggestion by the ADA. So a little bit of why we are now adding other crystalloids, so specifically lactated ringers. There was a great systematic review and meta-analysis of randomized controlled trials that basically, in this ongoing debate about normal saline versus LRs, that saline just was terrible relative to balanced crystalloids and all the parameters listed here. So we really should be moving towards balanced crystalloid. Nonetheless, it's kind of a low to moderate quality evidence, so they still kind of leave it open-ended. All right, so old on the left, new on the right. I'll just start out again, balanced crystalloids, which we discussed. Determining the tonicity of the fluid we give our patients used to be based off of sodium, so serum sodium level. Nowadays, we should be focusing more on osmolality. It has bigger physiologic impacts on the patient, particularly for HHS. And previously, if you guys remember your old algorithm, it's sort of package deal when you should switch over to D5 and half NS based off of the glucose metrics. At new guidelines, they want us to untether the two, treat for sugar targets and treat for osmolality targets separately. Just add the D5 or the D10 on top of whatever else you need there. We'll get into a little more nuance there in a moment. In terms of volume resuscitation, give a little bit more volume at the front end. And then once your patient is resuscitated, we should go for a slower free water deficit replacement. So instead of 24 hours, think more in terms of 24 to 48 hours. And this is to reflect that patients with diabetes are living longer. They're also going to get sicker with more comorbidities. So we're doing really well with that. This patient population is a little more fragile, so we should be a little more gentle. And that's what that reflects there. So I think this is probably the biggest practice-changing update for me is that HHS is no longer a set and forget admission bundle, and then you just tuck the patient in and just deal with pages as they arrive. We're going to have to be following these patients because we now have timed osmolality and glucose targets. So multiple parameters there that I'm listing here about how much to change per hour. So we're going to be watching metrics for these patients in the effort to not overcorrect, to protect our patients from cerebral edema and neuro complications. So it's going to be more hands-on. In terms of resolution targets, which are different, as we alluded to earlier, we don't look at the gap anymore. We look at beta hydroxybutyrate, and specifically BHB and not acetoacetate. Beta hydroxybutyrate is a little bit more accurate in terms of your cross-section of how the patient is doing. Remember that BHB oxidizes to acetoacetate, so it's a little sluggish. Venous pH is okay. You do not have to check an APG, and there are your parameters listed below. And we have 4 pillars of resolution for HHS. Again, it's going to be a lot more complicated. I'll just flag out cognitive status and urine output is something that we look at. So for practical sake, something for you guys to take away from this is your order set should look like this for both BKA, again, an emphasis on ketones and not anion gap, and for HHS. We are now trending osmolality for these patients. That is super important. So here are your guideline recaps, and I'm going to pass it back to you, Sean.
Well, hello again. All right, now I'm going to go over some specific articles that we found that were of interest. Starting with potassium. You know, there's always that old standby potassium 4 and magnesium 2, but those recommendations never had great amounts of data behind it. So this study's looking at potassium levels and arrhythmias. It was actually targeting a potassium level of 4.5 to 5. Is a randomized superiority trial done in Denmark. They included adults, and they specifically wanted patients with ICDs in place. Basically, they wanted patients who could have arrhythmias and have some amount of safety associated with it. It was not blinded. The patients were randomly assigned 1-to-1 in a 1-to-1 ratio. They measured a primary outcome that was a composite of sustained ventricular tachycardia, any appropriate ICD shocks, any unplanned hospitalization for arrhythmias, or death. They had a lot of secondary outcomes as well, including the components of that composite and some safety measures they kept track of. For their statistical design, for an 80% power, they eventually figured out they needed to enroll about 1,200 patients to have enough power. And they got that. They got 1,200 patients, and they randomized 600 in each group. I will point out that for the populations, they were mostly similar across the two things, but this trial ended up being very weighted towards the male population, with 80% being male. And the result was a hazard ratio that was in favor of the higher potassium goal, hazard ratio of 0.76, confidence interval crossing from 0.61 to 0.95. So suggesting that perhaps targeting higher potassium goals does, in fact, reduce arrhythmias. This is driven primarily by appropriate ICD shocks and ventricular arrhythmias. This is just a more visual representation of that information. Basically, the blue line is the higher potassium goal, showing that it's less incidence of the outcomes, including all of the breakdowns of the composite. The other thing that was of note, in one of their secondary endpoints, they looked at supraventricular arrhythmias and hospitalizations for that. And they also had a reduction here. Of course, there's a very, very low population for that. Not very many events. And since they looked at so many subgroups, you worry about the family-wise error rate in association with that. So not definitive for there. But overall, on this forest plot, you can see that in a lot of these groups and the breakdowns, there's a trend towards suggestion that a higher potassium goal might be beneficial. It's a good study, rigorous design. It's consistent with some other trials that have come out in the more recent past, like the Ephesus and Emphasis trial. And inexpensive. The biggest weaknesses is, only ICD patients were included in this trial, and they excluded GFRs less than 30, so not your renal patients. Since it was kind of country specific and male primarily, there's some problems about broadly generalizing this data, but at least there's at least some data to suggest these higher potassium goals might actually be appropriate. So treating to a level of 4.5 to 5 was kind of what they did, and reducing the composite of these arrhythmias might be beneficial. The next trial I wanted to talk about actually has a little bit of application to something Ahmed talked about, but basically it's the old standby question: lactated ringers or normal saline, which is better? And this trial, published in the New England Journal, tried to answer that question. It was done in Ontario, Canada. It was an open label trial where they included all patients that were admitted to all the hospitals that were enrolled. I will point out is regardless of exposure to the trial fluid, every patient admitted during the trial period was included in the analysis, which sounds like an intent to treat design, but it's not really intent to treat, because there's a whole bunch of patients that might have been admitted that they had no intent to treat with them with any amount of IV fluid who were still included in the trial. So it's not really intent to treat design. They were not blinded. It was a block randomization through a computer. And basically this is the flow chart of their kind of overall design. They took a hospital, and then randomized the hospitals to receive either fluid A or fluid B, which is LR or normal saline, and then had them basically primarily only stock that fluid for 12 weeks, and then switch and do the opposite for the following 12 weeks to have the hospital shuffle. And during the trial period, basically the stock should account for at least 80% of the total crystalloid fluids in the hospital. I will note the adherence in this trial to lactated ringers was certainly lower than the normal saline, down at 78%. The primary outcome was composite of death and readmission within 90 days. Secondary outcomes, they're looking at hospital lengths of stay and dialysis and some other important outcomes. The target sample size was set at 16 hospitals to reach the power that they were hoping to get to detect at least a 1% difference in the primary outcome. However, this trial didn't reach that power, was stopped early due to COVID. You know, that COVID always coming back. So this kind of an incomplete trial here. And again, I want to call out that all eligible fluids admitted, all eligible patients admitted were included regardless of trial fluid exposure. But it was a really big trial, had a very good population, and the characteristics between the populations were very similar. And for the primary outcome, they found no evidence of statistical significance. So this might suggest that there's no difference between giving these two things. But the things I want to call out, looking in this forest plot here, for the older patients, they actually found like a statistical significance. We can be worried about the family-wise error rate, whether this is just a statistical ghost or not. But in the older patients, there was maybe some benefit to balanced crystalloids, and in the sicker patients, maybe a trend towards benefits. In these populations as they studied it, at least. So their overall visual abstract things that they presented is basically no significant evidence of difference between the two. And it was a big trial, asking an important question, and designed to have large power, but unfortunately, due to incomplete recruitment, didn't have that large power. And I really want to call out this over-inclusion of patients unlikely to receive either intervention, because that would really bias it towards the no. All of these heart failure patients that we would admit, or COPD patients, or psych patients, all of these patients that we admit that we don't give any fluids to and don't plan to give any fluids to, every one of them is in the normal saline group, and in the LR group would bias towards no effect from the intervention because neither of them were getting the intervention. So why would it affect anything? So that makes me really worried that this was kind of not designed well to kind of answer the question, and it kind of designed to bias towards a null finding. But an interesting trial trying to answer this very common question. Again, those point estimates for sick or older patients maybe favor some benefit for balanced crystalloids, but kind of questions remain from this trial. I don't think it due to powering and design issues, it really answers the question for us. I will call out other recent trials that have been done recently that I won't go into depth, and other guidelines do have some opinions about that. So this guidelines, the surviving sepsis in 2021 still saying balanced crystalloid. The ADA that Ahmed just went over saying balanced crystalloid. The American College of Gastroenterology for acute pancreatitis recommending balanced crystalloid. European Society for Guideline for Intensive Care for these critically ill patients is also recommending balanced crystalloid. And some smaller trials that have come out recently. There's a perioperative trial suggesting benefit to balanced crystalloid, also for sickle cell and also in large volume resuscitation. There is another trial that's also come out, though, that favors saline in patients with TBI. So still, I think an important question with evidence to be developed, trying to figure out what is the best fluids. With so far from what I can see in the literature, a bend towards balanced crystalloid for a lot of situations. The final article I wanted to touch base on is talking about antibiotics for bacteremia. This is another New England Journal article done by the Balance investigators. It's a non-inferiority trial where they were trying to figure out if a shorter course might be appropriate. So they included all patients admitted to a participating hospital with blood culture positive for pathogenic bacteria. But they did have some exclusion criteria to that. And the really big one I want to call it here is they excluded Staph aureus and this other staph species that I'm not going to try to pronounce the last name of. But they excluded these gram-positive bacteria in their analysis and their acceptance for the patients. It was a randomized, they tried to mask it, but they could only conceal it for about 7 days, but 7 days for adequate treatment. So there was a little bit of unmasking in this trial. For the primary outcome in this, they were just interested in death. trying to figure out if there's any increased incidence of death. They had a whole bunch of secondary outcomes that they measured of some significance. But for their statistical design, for an 80% power, they needed a target sample size of 3626 was what they were aiming to go for their intent to treat analysis. After having all these patients, that they got about 13,000 that met the eligibility criteria. They were able to get 3631 enrolled, which is higher than that number, but unfortunately there were some dropouts, and so included in the intent to treat analysis, they only had 3608. So a little bit below what they had desired to get for their power. The population in general was fairly similar, but I do want to call out. That's right, it's a different side further ahead, but I'll call out something in a little bit. The difference in their results is they actually found that their non-inferiority threshold was they wanted it to not be worse than 4% in the 7-day group compared to the 14-day group. And their point estimate was negative 1.6%, which actually is a point estimate suggesting a 7-day would be better at that point estimate. But their confidence interval goes from negative 4% all the way to 0.8%. So possibility it could be as much as 0.8% worse, but also possibility could be as much as 4% better than a 14-day course. Certainly not crossing their non-inferiority threshold of 4%. Everything's over here on the left, regardless of the per protocol or intent to treat analyses that they did. So suggesting that maybe this is a safe thing to do. But the other things I want to pull out the grains of salt here is about 1 in 5 of those patients in that shorter duration group ended up getting longer durations of antibiotics. So 23% there, which obviously could bias towards a finding of non-inferiority. It's a possible outcome. Other things that they did find is as expected, the amount of antibiotics that the people in the shorter duration group got was less. They got less. They also had less hospital days, so they decreased length of stays. This is the forest plot kind of going over all these things. And you can see most of those bars and lines are over on the left-hand side of that non-inferiority threshold that they set there at 4%. But I want to call it this thing on the right here. For the pathogen, the gram-positive bacteremia and polymicrobial bacteremia widely cross that non-inferiority threshold that they set. And the numbers there are a lot lower than the gram-negative population. But it's a large population size with a meaningful outcome measure, so a decent study. But that weakness is that exclusion of the Staph aureus and other gram-positive bacteremias. And if you look at the total population, about 70% of them are gram-negative bacteremia. This is, I think, especially important to call out because a lot of other data recently has shown that in gram-negative bacteremia, these shorter durations are okay and safe to do, which combining them with the gram-positive bacteremia in the trial could bias towards a finding of non-inferiority when perhaps there is an issue with gram-positive bacteremia this trial might be missing that this thing does not capture. Overall, I would say it gives strong evidence towards that move towards a shorter duration in the gram-negative population. Perhaps some weaker evidence in these non-Staph aureus bacteremia, but the GPC population remains kind of unclear, I would say, still needing some more investigation. This is their nice visual abstract. So now I'll turn it over to Ahmed.
Thank you, Sean. All right. So aspirin in patients with chronic coronary syndrome receiving oral anticoagulants, also known as the aquatic trail. Dr. Pao talked about this yesterday in his excellent talk. So let's get through this pretty quickly so we can be on time for the rest of the event today. I think if you've practiced medicine, even for a short amount of time, you know that we've all been in this scenario. It's patients on an antiplatelet gets put appropriately on an anticoagulant, or vice versa. Blood thinner somehow picks up a diagnosis of coronary artery disease and is started on aspirin. So the study designed here is taking patients with CAD who are already on anticoagulations. And the question is, what's the appropriate antithrombotic regimen to prevent stent thrombosis? Or if the patient doesn't have a stent, how to mitigate high atherothrombotic risk. So a little definition here is chronic coronary syndrome. It's a very inclusive definition, basically CAD, not in an acute phase. And here is our inclusion criteria: adults, coronary artery disease, and they're already on an anticoagulant. So about 900 patients, underrepresented in terms of gender, mostly men. And the trial design was prospective, double-blinded, randomized, placebo-controlled, and importantly, a French study. So they either got blood thinner plus aspirin or blood thinner plus placebo. And in terms of efficacy endpoints, the trial was stopped early. For this primary composite at the top here, where patients did worse on the treatment arm with aspirin plus a blood thinner relative to placebo, that's a hazard ratio of 1.53, statistically significant. Visualized in terms of the endpoints over time, you can see that it separates really nicely with worse outcomes for the treatment folks. And then tethering out death from any cause and major bleeding, we're seeing a whopping jump in hazard ratio of 3.35, and death from any cause is also increased as well, both statistically significant. So our takeaways is adding aspirin is actually the worst of both worlds. And I think this is not surprising for bleeding risk with a number needed to harm of 15 really low. That makes sense to me. I was surprised, I wonder if you guys are too, that we actually see more thrombotic events in an antiplatelet and a blood thinner with a number needed to harm of 21. So this was surprising to me, and I'm sure surprising to many of us who've engaged in decades of practice where we want to treat with antiplatelet to keep those coronaries nice and open. So there are limitations to the trial. Statistical power diminished because the trial had to stop early. It's also a single country study, so there may be healthcare and system factors. But ultimately, this does align with similar previous trials, the AFIRE and EPIC CAD studies, where they showed a wash in terms of the antithrombotic benefit. So kind of to wrap us up here, don't give an aspirin in addition to an anticoagulant because you're getting the worst of both worlds. And then the takeaway of this takeaway is that human bodies are complicated. Just because things make sense, we don't have these separate systems that we get to tweak in a vacuum that sum, independently to something better. Things are very complicated and do cross over. And very importantly, I just want to resonate with Dr. Dean and Dr. Bassel were talking about the other day, is that science is complicated, but it's awesome. Let's not be cowed by uncertainty. And to borrow from a professor and author, our ability to make the most of uncertainty is what creates the most potential value. And where certainty ends, progress begins. Thank you guys so much.
Thank you so much, Dr. Salahuddin and Dr. Schweitzer. We appreciate you bringing us back from that early presentation turbulence. I do have 2 questions for you. Are those with chronic Foley or suprapubic catheter to be classified as complicated UTI in these new guidelines, or is that implied?
That is a great question. So the short answer is they are, believe it or not, not auto-classified as complicated. However, the guidelines do list out in the manuscript that patients with what I would call hardware, so stents, suprapubic catheters, and indwelling Foley catheters, are generally unlikely to have uncomplicated UTI. So that's the very interesting roundabout language for that the IDSA gives us. So it just leaves a little bit of opening for interpretation. Again, I think to fit the theme, to kind of focus on your individual patient in the aim to be better antibiotic stewards.
Great. And then from another panelist, any updates on asymptomatic bacteriuria treatment in high-risk patients?
No updates there. Treatment is not indicated for those asymptomatic bacteriuric patients. Still follow the symptoms and the extension.
Okay. And one last question. For the last study, was there a mechanism proposed for why there were more thrombotic events in patients on anticoagulation and aspirin?
No mechanism proposed. I think we are still in need to dig into that. Again, just a complete curiosity as to, and just an emphasis on how complicated the clotting cascades are on these 2 separate systems.
Great. Thank you guys so much again.